Hey, good morning, everyone. Thank you so much for coming bright and early, especially after a rough Phillies game last night. Hope everyone was up late, socializing, enjoying the time. But we appreciate you coming to our session this morning. This session is entitled Insights to the Unique Needs of CF Across the Lifespan. My name is Jen Stewart. I'm a nurse practitioner, and I'm co-chairing this session with Heather Brosius, who is an RN. In this session, we're first going to have Heather speak to us a little bit about education committee updates. Then I will present about feeding therapy in a CF clinic. We will then hear from Donna Germuga, who's going to teach us about home spirometry coaching. Hillary Vogt will then speak about polypharmacy in adults with CF. And then we'll hear from Kristen Clem with the Foundation about food insecurity and cystic fibrosis. So we've got a great program this morning. I did want to mention on the app, if you click into your session, there is a Q&A tab. You can actually type questions in that box, and then they'll come up to us. We can address them in between presenters and at the end of the session. And now I will turn a few minutes over to Heather, who will talk to us about the Education Committee updates.
Good morning, everyone, and thank you for being here. So the Education Committee is a group of pediatric and adult specialists, a variety of members on the team, and we do represent all disciplines. Our term is 3 years, and it's based on an application process in which they consider experience with CF, your experience in creating and reviewing different educational materials, and then also ideas for the development of CF education. And if anybody's interested in joining the committee, the next round of applications will start in the spring of 2025. This is a list of all of the current members on the committee, and also a picture of the committee meeting from last year's NACFC. And please note that not everybody on the committee is in that lovely Zoom photo, and the members who are rolling off the committee this year are not listed here. So what do we actually do as committee members? So we review all of the educational materials that are submitted, and then we will give feedback to the authors. And if they choose to take that feedback, we can give an education committee stamp of approval. Sometimes the authors choose not to take that feedback, and we'll still include those things as resources. They just don't have the committee approval. And so we look for things like accuracy, things that apply to more than just one specific center. So does it apply kind of globally or to pediatrics or adults specifically? And to ensure that the educational materials are at an appropriate reading level. We also review the educational abstracts for NACFC and improve access to those materials. And all of the materials that are approved can be found in the resources guide. So since it's been a while since we last presented, these are all of the resources that have been approved since 2019. And there are examples here on the next slide as well. So there's an herbal product information sheet. There are 2 modules or 2 quizzes in the CF RISE program, the Right CF screening tool, and then there's also one called When There Is Smoke, There Is Fire in Your Lungs. And again, these can all be found in the Education Resources Guide. And this should have been shared on all of the listservs at this point. If you haven't seen it come out on your listserv, please let us know, and we'll make sure it does get sent out for everybody. So if you're not sure how to find resources, there's a lot of them out there, and some of them are really great. I would start with either looking at cff.org or in the my.cff resource library. And if you're looking for something in print, you can also send an email to the address listed there, and I'll walk you through quickly how to order things in print here on the next 2 slides. So this is what your MyCFF portal looks like. If you've never logged into it, I would encourage you to do so. There's a lot of cool things in here. This is where the listservs are housed, where you keep your care team updated, and then of course where you can order the educational forms. You would click on the order forms. That's going to bring you up to this next slide. And all of the things that you can actually order in print are listed here. You put in the quantity that you want and then just follow the process, and they will send you the resources that you need. If you have any questions, the email address to reach out to is listed up there. And so what can all of you do? So certainly send us educational abstracts for NACFC. There's a lot of great topics out there, and it's a lot of fun kind of reviewing and seeing what people are working on. The emails for needs assessment surveys, please respond to those. You can notify the education committee if there's materials that are out of date, if they have broken links, if they're just not working anymore, and we'll make sure that those resources do stay up to date for you. Distribute the education to the CF community globally, and then lastly, submit resources for us to review. All right, if there's any questions, I can take those at the end. We'll keep the session moving here for everybody. So I'm gonna turn it back over to Jen, and you can certainly introduce your topic then.
Great, thank you.
All right, thank you. For those still coming in, there are still some seats up in the front here. All right, so again, my name is Jen Stewart. I am a nurse practitioner in Salt Lake City, Utah, Primary Children's Hospital. And today I'm going to be talking about the utilization of a speech-language pathologist to provide feeding therapy in a pediatric multidisciplinary CF clinic. And I was going to be presenting today with Kimberly Herte, who's the speech-language pathologist at our center. She is expecting her first baby any day now, so she was unable to travel with us today. She's back in Utah enjoying the first snow of the season. But certainly we want to recognize her and appreciate all the work that she's done and contributed to this project. I have nothing to disclose related to this presentation. So the objectives today, we want to define pediatric feeding and swallowing disorders and understand the role of a feeding therapist, identify how a feeding therapist can support patients with CF, and then understand the benefits of adding a feeding therapist to a multidisciplinary CF clinic. So first I want to talk a little bit about feeding and swallowing. Something that we do routinely without really thinking about it. It's typically a smooth process and fairly easy. Feeding is defined as a process involving any aspect of eating and drinking. It can be both social and behavioral. Swallowing is a bit more complex. It's a complex process during which saliva, liquids, and foods are transported from the mouth into the stomach, all while keeping the airway protected. There are 4 different phases of swallowing. Some are voluntary and some involuntary. There's an oral preparatory, oral transit, pharyngeal, and then esophageal phase, which the esophageal phase is the involuntary phase where the food's carried down to the stomach through the process of peristalsis. Unfortunately, this process does not always go so smoothly, and we do see pediatric feeding disorders on occasion. Feeding disorders is identified as impaired oral intake that's not age appropriate and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. The different categories of these disorders, they can be medical, where there's impaired structure or function of medical systems, nutritional, where there's restricted quality, quantity, and variety, and that leads to the risk of malnutrition or overnutrition. We can have deficiencies, toxicities, and dehydration. There's feeding skill disorders where illness, injury, or developmental delay leads to impairment of these feeding skills. And finally, psychosocial, where factors within the child, caregiver, and feeding environment affect feeding. And feeding disorders are fairly common. So we know that feeding disorders affect more than 1 in 37 children under the age of 5 in the US each year. Swallowing disorders also occur. They can occur in 1 or more of the 4 different phases mentioned before of swallowing. So, there's oral phase dysphagia, pharyngeal phase dysphagia, and esophageal phase dysphagia. many different signs of pediatric feeding and swallowing disorders. I won't go through them all, but they're listed here. Often you'll hear about or see breathing difficulties when feeding, coughing or choking during or after swallowing, frequent respiratory illness, chronic constipation, diarrhea, vomiting, crying or refusal during meal times, taking small amounts of food or refusing foods, difficulty chewing, excessive gagging, long meal times. These are all kind of red flags that feeding is not going so well. And we wanted to review just basic feeding development. So in the newborn phase, up to 6 months of life, most babies are breastfeeding or bottle feeding. Then around 6 months of age, or as they start to show cues that they're ready, we start to introduce solid foods and cup drinking while continuing the breast or bottle feeding. Around 9 to 10 months of age, the child should be eating a wide variety of solid foods 3 times a day. And then by a year, typically starting to wean off the bottle or breastfeeding and the child becomes more dependent on solid foods and cup drinking for all of their calories and nutrition. And of these development stages, I would say the one we probably see lacking the most, at least in my experience, is around that 9 to 10 months of age, where a child should be eating a wide variety of solid foods and really should be getting 3 solid meals per day. There's lots of different treatments that we can offer children who are struggling with feeding and swallowing. In that infant stage where they're bottle and breastfeeding, there's things as simple as position changes that can make the world of difference. Bottle and nipple changes, pacing strategies, a feeding schedule modification. We can recommend swallow studies or thickened liquids to help them feed better. Reflux strategies, managing that reflux better is very helpful. And then throughout this presentation, I did include Ellen Satter, who's a dietitian that works and focuses a lot on feeding. Her strong recommendation is that caregivers are responsible for what, when, and where, but the child is responsible for whether or not and how much. Those of you who have children or can imagine know that it's difficult, if not impossible, to force a child to eat, and often makes things worse. You end up going the other direction. We want children to have positive feeding experiences. So a lot of times it's educating the caregiver that they're responsible for what, when, and where, but the child's responsible for whether or not and how much. As the child transitions to solids and cup drinking, there's lots of different treatments there too. Again, position changes, trying different approaches, feeding schedule changes, and balancing the caloric beverage with solid foods, self-feeding, child-directed, different textures, play strategies, modification to the caregiver's behaviors, cup modifications. Again, we want to make a positive feeding experience. If there are behavioral and sensory feeding difficulties, routine is really helpful. Food exploration, offering lots of different choices. Again, what, when, and where, and then the child is responsible for whether or not and how much. And ultimately, examining that parent-child dynamic and trying to create a low-stress, positive experience. So what can clinic providers do to support positive feeding development? We're in a room largely of nurses, and I know nurses really excel at educating patients and families. Education is huge, and that's big here. We want to teach caregivers about typical feeding development, kind of what to anticipate and what to expect. We want to discuss and educate caregivers on different options and approaches for feeding their child. Certainly, one thing does not work for everyone. If something's not working, switch it up and try something else. We want to empower caregivers to understand the different options and choose what is best for their family, and discuss the importance of feeding behaviors, positive meal times, and good relationships with food. And then something that's difficult and we don't always feel like we have time for is being flexible with different approaches and recommendations. And then, of course, if caregivers are reporting concerns with feedings and mealtimes, we would recommend referring to feeding therapy for additional support. So I want to talk a bit more about CF specifically and pediatric feeding and swallowing disorders. One thing we know for sure is that we need more research related to CF and feeding and swallowing disorders. But the research that we do have shows a higher prevalence of feeding disorders in infants and children with CF compared with their healthy control subjects. Of course, there's an emphasis on growth and nutrition from the very beginning of diagnosis. This often causes parents to use more force and pressure to try to increase volumes and caloric density and just really trying to get those calories in. Often there are pressure-based interventions which only increase the problematic behaviors. A child often resists and goes the other direction. GI distress can also contribute to refusal and volume limiting. If there's slow motility, constipation issues, that certainly can affect feeding. Respiratory distress can make swallowing more challenging. And then feeding tubes, while they are great and at times necessary, they can also reduce oral intake. And that's certainly something that I've seen in my practice. Kids that have been very dependent on G-tube feeds just really don't like to eat or want to eat and are heavily reliant on those enteral feedings. Powers is one of the papers that we studied with this presentation, and a quote from this paper was that direct observation of mealtime behaviors indicates that parents of infants and toddlers with CF engage in more mealtime management behaviors than parents of controls, and that young children exhibit more behaviors incompatible with eating as the meal progresses. He also states that achieving the cystic fibrosis dietary recommendations is challenging, and typical parenting strategies to encourage eating not only are ineffective but may have a negative impact on family functioning. To improve dietary adherence and decrease conflict at meals, children with CF and their parents need to be taught more effective management strategies as part of dietary counseling. This is certainly something that we recognized within our clinic. We needed more education and support, especially for these young babies when it comes to feeding and development. So again, we know optimal nutrition and growth are associated with improved outcomes in CF, and these high caloric goals are often very difficult to meet for infants and young children, especially as we're introducing pancreatic enzymes and salt and things that are difficult at times for a baby to take in. Children with CF can develop oral aversions and other feeding problems which lead to nutritional deficiencies. And we really would like to get ahead of these problems and intervene and educate earlier so that they don't become chronic and affect their overall nutritional status. So these interventions at an early age are necessary. We definitely recognize the benefit of having a speech-language pathologist involved in CF care. However, there are barriers. Nothing's ever as easy as we want it to be, right? A speech-language pathologist can provide many of these interventions. However, there's barriers to accessing. So one thing we recognized is that there's additional appointments needed for feeding therapy appointments. These children are often already medically complex and coming multiple times per year into clinic, so adding additional appointments was difficult for families. We also cover a large geographical area, and so the distance to additional appointments was difficult, or transportation. We also recognized with different insurance payers that there was different coverage or refusal of feeding therapy, so insurance was difficult. We also recognized with outside referrals that there was a lack of familiarity with CF-specific recommendations among different feeding therapists. And we would hear feedback when families went that either it wasn't really helpful, or they were hearing contradicting information, or they were not able to be seen consistently And that's another barrier, continuity of care, seeing someone as frequently as they need to, and someone being consistent with those recommendations. So we made a goal at our clinic to improve access and utilization of a speech-language pathologist who could provide feeding therapy for CF patients and improve feeding habits and overall nutritional and pulmonary outcomes for pediatric patients with CF. The process, we first identified an excellent feeding therapist, and this is actually what gave me the idea. I started referring, and rather than just referring out into a black hole, I started hearing back from this one specific feeding therapist. She was so great to communicate and said, "Hey Jen, I saw this patient. This is what I think. This is what I'd like to do. Where are you at? What are your recommendations?" So really closing that loop and communicating and making sure we were all on the same page made all the difference. She had outstanding communication with our team, and I realized we need her to be on our team more consistently. Parents also provided positive feedback related to their experience with this specific feeding therapist. So we had, of course, I talked to her, had the idea, would you just come to clinic and be a part of our clinic for a portion of your time? She was interested, we were interested. So we met with the CF Center director, who's extremely supportive. We were lucky for that, and hospital administration. And we gained approval for a portion of speech-language pathology time, so one specific pathologist, her time to be spent in a multidisciplinary CF clinic, using the CF grant to help cover that position. And this helped eliminate many barriers, increased access. There was no additional cost to the patient families, no additional appointment, travel time, and as someone familiar with CF and very consistent in their recommendations. Whoops. So we notified families of the new CF feeding clinic in a monthly newsletter and worked with our scheduling team to add specific templates that were held for these patients, so that we could utilize those spots in the best possible way. And then we had her provide education on feeding therapy and feeding issues to our entire CF team so that we were more aware and conscious and educating on these behaviors so that we could refer the right patients into these clinics. We also created different educational handouts for families and purchased some different tools like the Honey Bear straw cups, sipping cups, those kinds of things that could be used in clinic for these to help these patients. We started with combined CFGI feeding clinics in March of 2021. We have a clinic with all the multidisciplinary team members. The GI clinics also include a gastroenterologist, and we had our speech language pathologist come to these clinics. With increased demand, we started filling these clinics pretty quickly, so we increased to just from once monthly to twice monthly by November. This clinic is open for any child with a need for a feeding therapist, but there is a focus on kids younger than 2 years of age. We made a goal for all of our infants at our center to be seen in this clinic within the first year of life. And the purpose of that is to assess feeding, educate on those developmental stages, and really try to intervene early on if needed. Ideally, timing, if it works out, is around 3 to 6 months of age to provide education and assess for barriers as the child is starting to transition over to solid foods. And we've been pretty successful. You can see on this chart, of all of the children in our center, less than 2, we have had 78% of them seen at least once in this clinic by the feeding therapist. 81% have been seen less than 1, and 75% of children from 1 to 2. So that has been, we've had really good response rate from families coming to this clinic. We've also been able to increase our referrals and the number of patients who are actually seen when referred. So prior to this clinic and having an identified speech-language pathologist as part of the team, patients were referred to outpatient feeding therapy, but again, due to multiple barriers that I had discussed, patients did often not schedule, or they felt like they didn't receive any benefit from going to that appointment. You can see on the chart below, on the lower end, these were our referrals prior to having an identified feeding therapist. Of 17 patients referred, only 12 of them were actually seen. And then once we had an identified feeding therapist and someone as part of our clinic team, not only did the referrals increase, but the number of patients seen by that referral is significantly higher at 91%. And these are, again, referrals outside of clinic, not those seen as part of the CF feeding clinic. So one thing we didn't want to happen was to extend the length of the visit. We know that CF clinic visits are already lengthy and difficult for families to see everyone on the CF team. So we decided as our process to have the feeding therapist go in with the dietitian and sometimes with the gastroenterologist as well. This reduces the repetition and also helps to make sure that we are on the same page with the plan and not giving conflicting information. So the dietitian and the feeding therapist ask the caregiver questions related to feeding and swallowing, discuss mealtime routines, talk about different foods accepted. Oftentimes our feeding therapist will observe feeding in clinic and then go over recommendations with the caregivers, and then they also collaborate with the rest of the CF team outside of the clinic, outside of the patient room. And of course, anything we do, we want to measure the outcome and see if it's really helpful and effective like we think that it is. So we came up with a survey to give to the caregivers at the end of the visit. And we wanted to keep it fairly simple. We know that survey burnout is a real thing. So we just came up with 5 different questions and had the families rate whether they strongly agree or strongly disagree. The questions were: consulting with a feeding therapist improved my overall experience at my child's CF clinic appointment. My questions and concerns regarding feeding my child were addressed. The information I received today was helpful. I feel confident that I will be able to carry out my child's feeding plan at home, and I would like to continue to see a feeding therapist during my child's CF clinic appointment in the future. This is what the survey looked like. Just fairly simple, check the box, and then down at the bottom there's room for any open comments. Of the surveys that we handed out, we got 27 parents who participated, and the response was pretty overwhelming. All of them felt like having a feeding therapist improves their overall clinic experience, that the information they received was helpful, they really appreciated having an individualized feeding plan for home use, and that they would like to continue to see a feeding therapist during their child's CF clinic visits. Of course, we love that survey, but we also always appreciate a good patient experience and hearing and seeing how these actually impact patients and families. So I want to share a couple of case studies. First off, we had a 14-month-old male who was accepting formula via bottle, but even at 14 months old, had minimal acceptance of solid foods. He would only eat 3 things: tater tots, taquitos, and crackers. While these are delicious foods, they are probably not fully the best food choices. Caregivers inconsistently would offer solid foods and rarely offer new foods, and he was not drinking out of a cup at all, just very dependent on the bottle. This child's mom reported a lot of stress with feeding her child solid foods. And I will say, she's a first-time mom, had a child born in the pandemic, and coincidentally, right as her child was diagnosed, there was an earthquake in Utah. So high stress scenario for sure. But this child was seen in feeding therapy in CF feeding clinic a total of 4 times, twice in clinic and 2 outside of clinic. And within just 4 sessions, he was eating 3 solid food meals per day, drinking high-calorie beverages and water from different cups during mealtimes, accepting 1 bottle before bed, eating a variety of foods without difficulty, and consistently trying new foods. And mom reported she now enjoys feeding her child and feels confident in how and what to give him. So it was a huge success story, and something that we felt like we were able to offer interventions before he had significant nutritional decline. Another case study, we had a 3-month-old female seen in CF clinic by feeding therapy. She had a history of poor weight gain. She was actually born tongue-tied, so feeding was a little bit more difficult for her. She would take small volumes, poor quality of feedings. The feeding therapist was able to modify the position, change the bottle, change the feeding schedule, and miraculously, she had improvements. Initially, there was small improvement, but feeding therapy was able to see them for additional visits outside of clinic, and some of those were virtual. And after the additional clinic visits, she had improved weight gain, appropriate feeding, and improved quality of feedings. So again, we were happy to see where these interventions made a big difference. In conclusion, I will say that having a feeding therapist or a speech-language pathologist as part of the CF team definitely increases the utilization for patients to benefit from feeding therapy. The combined clinics decrease the burden of care and improve overall patient and family satisfaction. In collaboration with a dietitian, gastroenterologist, and other members of the CF team, a speech-language pathologist offers individualized feeding plans and educates families on feeding issues. And by providing increased access in clinic, we hope to increase overall patient family satisfaction and offer earlier intervention, optimizing nutritional and pulmonary outcomes in CF patients. Of course, something that we're always trying to do is improve the lives of patients and families with CF. We do have a poster if anyone is interested in viewing or discussing more about this clinic, and these are my references. We will now just have a couple of minutes for questions and answers. If anyone was able to submit anything through the app, or you're welcome to stand and yell out a question as well.
I don't see any questions on the app yet, Jen, but I'll throw one out for you,
Sure.
maybe to get the creative juices flowing here for everybody. Do you have any involvement with psychology and or child life, especially in the cases where there's behavior issues or, more so of a refusal to eat rather than something, like structurally wrong?
Yeah, thank you. That's a great question. We definitely do include our social work team members and we're lucky to have a psychologist on our team as well. And certainly that is helpful with feeding. And luckily in this specific clinic, we do have those team members available as well. So we do rely heavily on them and their opinion and expertise. There are individual appointments with our psychologist available if needed, or if we can also find resources closer to home for the family if needs be. But I will say in my observation, once we're able to change routine and just that parent-caregiver relationship with food, things seem to work and go much better. Any other questions, comments from my team? Yes?
What's the size of your CF population?
Thank you. Yeah, the question was, what is the size of our CF population? So we're in a pediatric CF center, and we have around 320 patients. Good question. So that certainly is something that we're looking at and trending over time. The difficulty is that there are so many factors that of course contribute to that, so it's hard to say exactly that feeding therapy has helped, but we have seen overall improvement in weight for length percentiles and BMI percentiles through the registry center data. All right, well, thank you guys so much for your time. If anyone has any additional questions, feel free to type them into the chat box and we can answer them at the end. And now I will introduce our next speaker. Let's see. Okay. So next I'd like to introduce Donna Germuga. She is going to speak to us on some different home spirometry techniques.
Hi, good morning. Thank you for having me. I am going to talk a little bit about home spirometry. I am the respiratory therapist at both adult and pediatric center of the University of Rochester in Rochester, New York. I did vet these slides through the nurses in our office, who are often called to fill in for me if I'm doing something else, and they really gave me some good suggestions about content for this. My disclosures are that I do home trainings for both Hill-Rom Baxter and Respirtech Phillips as a clinical trainer for their vest therapies. Why do we use spirometry? I mean, we talk about it in clinic all the time. It's a basic pulmonary function, and we want to know if lungs are holding as much air as they should and moving that air the way they should. So restriction is the lungs are not holding as much air as would be predicted based on gender, age, and height. And obstruction, excuse me, is that the lungs aren't moving the air out of the lungs as fast as we would predict. So we're always talking about FEV1, 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 and that is important, but we really have to look at FEV1 in context with the whole number, the whole breath, the amount of air, which is the forced vital capacity. When you take a breath in as deep as you can and blow out till you can't blow anymore, that's your forced vital capacity. The FEV1 is how much of that air comes out in the first second. So if you look specifically at FEV1 and nothing else, you really could be lulled into thinking something is there that's not. The example I give here is that if a patient has had a lobectomy and a third of one of their lungs is taken out, you can't expect the same amount of air to come out and the same percentage of that air to come out because part of the lung is missing. So if you look at this PFT, you might look at that FEV1, the top number, and say 39% predicted. Oh my God, that patient is terribly obstructed. We've got to do something. But then if you look at the forced vital capacity, that's only 40% predicted. So in fact, when you look at those two numbers together, which is the FEV1 FVC compared to FVC number, the patient's actually getting out 100% of what's predicted in the first second for that total amount of air. Hopefully that makes sense. So these are just cartoon pictures of what different flow volume loops might look like. A normal is sort of the triangle like a sailboat. Obstruction has that sort of C-shaped limb. And I should say, for those of you not used to looking at spirometry, the exhalation is on the top of this graph and the inhalation is at the bottom. Restrictive lung disease, it tends to look more tall and narrow. If you have patients in your clinic who are pregnant, you may see the shape of their graph change over time as their girth increases. So some of the things you might see when you're looking at a spirometry is that the top right, or the top left, I'm sorry, is somebody coughing during the maneuver. Top right is a good maneuver. The next one down on the left is they basically, we're telling people blow, 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 and very often people go, huh! And they feel like they're pushing as hard as they can, but there's no air coming out. And so you really have to encourage people to kind of push from their abdomen. And then the middle on the right is, you can see just a little bit of a gap on the beginning of exhalation. And while that isn't a huge amount of air, it shifts the whole graph over a bit to the left, which will make your FEV1 reported higher than it actually is. So if you're using these to make clinical decisions, you really want to make sure that the technique is good. And then the bottom two are just, the bottom left is just sort of variable efforts. The first one is a good hard blast, and then subsequent ones get, a little more blunted, and then the one on the bottom right is probably somebody who doesn't want to go to school or go to work, and so they basically do that. And we have, so the American Thoracic Society says you have to have 3 efforts within 3% of each other for adults, or 50 mLs in order to consider it a good test. So if somebody can't, like the graphic on the bottom left, if somebody isn't giving a maximal effort, it's really, really hard to reproduce that. So that's why we do 3. It's an effort-dependent test, and the patient has to be able to do similar maneuvers several times in a row in order to say, yeah, okay, I can believe that. The caveat to that is if somebody has spirometry-induced bronchospasm, it'll look like it's a nice point on it, but each successive one gets a little smaller, and people then tend to not feel well. So this is the home spirometer. This is the spirometer, and this is the nurses in our office were like, well, you're doing this thing on home spirometry. We don't know what that thing looks like. This is what the home spirometer that the CF Foundation has provided for people. It comes in 3 pieces. There's the handle, the turbine, and the mouthpiece. The middle picture is the turbine being placed correctly. The picture all the way on the right with the mouthpiece, you can see the orange sticking out the back isn't quite as prominent as the middle picture. That needs to be fixed, or your PFT is not going to be correct. So this is one of the things that comes up with people like, well, I can't get it to work, and it's not reading right, and the numbers are all over. To have them check to make sure that things are aligned correctly is really important. So the Breathe Easy app comes with this. You download it for free, and these pictures pop up when the patient gets ready to do their therapy or their spirometry. So you click on the FVC button because that's what you're going to do. They have to fill out their health demographics. One of the things we learned early on was the health demographics picture comes up and it'll have today's date, whatever today is, and people see a date in there and they keep going and don't put their birth date in there, and then nothing works because you can't do spirometry if you were born today. So, and the height especially needs to be as close to accurate as possible because that's really a big factor. Age and height are really big factors in the algorithm that predicts what your values should be. Then there's this little box that pops up about sharing. If your center uses the dashboard, the patients can share the information with the dashboard. I just learned yesterday that the CF Foundation does want them to share the data with CFF because they're tracking who's using this. Then you go over to all the way on the right and it tells the patient how to do the test. And then it gives instructions, breathe out, breathe in. The third picture is your results that you get, and then the thing gives you a thing that says great job, and it'll say we still need another test. And so if you see that, you know the patient didn't do enough efforts to for it to qualify as meeting the ATS standards. This is one of the nurses from my clinic, and she very nicely said that she would do a spirometry for you all. And so a couple things I want you to notice. One, I didn't make her put nose clips on. That was an error on my part. And the spirometer, the little paddle, if they bring it up real quick, sometimes it'll start to read and it'll kind of muck things up. So you have to have them sort of gently put it in your mouth. And then when this video starts, you'll see that she puts it in her mouth, and then I say something, and then she puts it in further. She puts it in first in front of her teeth and just her lips around it, and I ask her to open her mouth and put it all the way in her mouth so that the air doesn't get slowed down by that. Hopefully this will work. There she goes. See, she's ready. There she goes. And she's pushing, and she's using her abs. She's pushing. She may be trying not to wet her pants. She has 4 kids. So that was really quite excellent. So some of the difficulties, we get poor technique if they're doing it independently. They're not giving enough reproducible efforts. A lot of times the app won't connect, the batteries are dead. It's really difficult to tell the accuracy or the effort level without seeing that loop. So our center still is not able to access the dashboard, and so they're sending me just screenshots of what they did, and if I can't see a loop, it's hard to determine. So, which is fine, most of them are very practiced, but if we're making clinical decisions about starting antibiotics and you're not sure about the effort, then it's kind of a tough thing to say. And I get a lot, I'm in my car on lunch, I don't have my spirometer with me, I don't this, I don't that, and sometimes you just don't believe the results. So if a patient consistently sends poor efforts and they say they're feeling fine, there's no cough, there's no sputum, there's no anything, I think it's best to just connect with them either via video if they're going to do a video visit. Our center is still making people do PCR tests before they come to do PFTs. So I will, if they're coming to do PFTs, I'll ask them to bring their home spirometer with them so that I can coach them and we can compare the two numbers to the office machine and their home machine to see if there's much of a difference. If people are having issues with the app, there is a video, YouTube videos you can go to, and the ZephyrX support has been really, really responsive. They email me back very quickly and really work hard to resolve. I've done several video appointments with them. So I try to send, every Wednesday I have it on my calendar to look at next week's schedule and see the people who are coming in person. I send a message to say, hey, get your PCR test done. The people that are coming virtually, I say, hey, don't forget to do your spirometry sometime between now and then when you feel like you're up for it. I was texting from my phone because nobody reads my chart messages and nobody answers their phone or listens to messages. So that resulted in many people having my cell phone number, which has not been great. And so the Doximity app, if you're able to use that, our center it does have a text option now, so I put in the number, the main line for the office, and that's the number that they see pop up, so they don't have my cell phone number. I mean, they already have it, but so the next time the patient comes in person, have them bring their spirometer, you can check their technique and different things, and ask them to designate a spot on top of the refrigerator, in the top of their closet, where they're gonna put it every time, because I can't tell you how many people have said, I don't know where it is, I lost it. I'm like, well, it didn't sprout legs and go away, so it's there somewhere, and they really need to be a little concrete about where they're keeping it. So the dashboard, we're trying desperately to access this dashboard. The dashboard does a couple things. You can send a request for a video appointment through the dashboard so that you can see the patient doing the spirometry. At the same time, you see the loops, you can correct technical errors, things like that. And the issue is that it's a fee. It's $15 per patient per month that use it. Not every patient, it's only the patients that use it in that month. In our center, they did a financial review and they found that the billing for the interpretation more than pays for that $15 a month. We're just fighting with ISD because they're ISD, I guess. But you can really see what they're doing. You can judge it for accuracy and reproducibility and see if they're, that one graph that had the bouncy like cough, it'll also look like that if somebody's sticking their tongue in the mouthpiece, and because that'll slow down the air, but it wiggles, and so you can really check to see what is happening. So that is what our nurses have told me was important to them, and so hopefully you got something out of that. Does anybody have questions for me?
How's the home spirometry?
I'm sorry, I can't.
How is the home spirometry cleaned?
cleaned. So the turbine basically is led to air dry, and the mouthpiece you can take off and you can clean with alcohol. And there's no other parts other than the paddle, so you can wipe that all off with a Clorox wipe or whatever you want. But the turbine, basically, the most important thing for that is to allow it to dry in between so that stuff doesn't grow. Yeah.
Found any ability to replace lost?
No, I had somebody whose mouthpiece cracked, and I did get a sheet from Zephyrex that had like prices, and like a replacement mouthpiece was like $3. You can buy replacement pieces. People have cracked, lost, whatever. The CF Foundation is not replacing any of those, but I did get information on where to order from and how much each item would be.
How are you actually getting your patients to use it?
That's patient specific. Yeah, so it's difficult. It's a lot of prodding. That's why I text a week ahead, and I watch in the chart to see if the PCR test has been done, and if it hasn't, I then call them or text them again and say, hey, I see you didn't get your PCR test done. Can you send me a home spirometry even though you're coming in person? It's just constant badgering, basically, and I probably get about 75%. Did anybody else have a question? Yeah.
At what age do you find that PFTs become reliable?
I mean, in peds, because they're repeated so often, I would say around 6 or 7, depending on the kid. I mean, sometimes they're still, we have a spinny chair in the lab, and that could be, that could derail everything. But if they've done it enough and they're sort of serious enough, around 6, I'd say between 6 and 8. Yeah, did you have a question in the front?
I was just wondering where they could get it, like where they obtain this spirometry.
The unit, so yesterday I found out at the coordinator's lunch that currently, if it's a new diagnosis patient or a newly transitioned patient that doesn't have one, the CF Foundation is still providing those. So you send it to Zephyrex, and they will send it out. The CF Foundation is actively trying to pull out of that agreement because they've distributed something like 19,000 of these. We're running into a problem that the peds stocks don't necessarily feel like they believe what the spirometry says. So now I've got people transitioning over to the adult side that want to do video visits that don't have spirometers. So, it's going to be an issue.
Donna, we do have one question for you from the app, and this will be our last question so that we can stay on time. The question is, what is the cost of home spirometry and insurance coverage?
It's really dependent on the insurance. And the home spirometry, we don't bill for that. What gets billed is the physician's interpretation, and they do that within the encounter and the electronic medical record. So I think that they get somewhere in the neighborhood on average of something like $38 for an interpretation, and so the cost of that would be $15, so you come out on the plus side, and so everybody thinks it's worth it, but ISD is having a hard time with it. Thank you so much.
Thank you.
All right, I will announce or introduce our next speaker. Our next speaker is Hillary Vogt. She's a clinical pharmacist with Indiana University Health.
All right, good morning, everyone. So I will jump right in here. I am the adult pharmacist at IU Health in Indianapolis, and I do not have any disclosures for my presentation today. So since a talk on adult polypharmacy in a CF population could probably last the whole entire CF conference, I have 3 main areas that I'll cover, and so that is, what is polypharmacy? why is it important for us to understand as a group of people taking care of those with CF, and then a little bit on medication interactions and some common comorbidities seen in adults, and I'll cover their treatment briefly. To start off with polypharmacy, there isn't one solid definition for what that is, but as the name would suggest, it's the use of multiple medications to treat one or more conditions in a single patient. Some concerns that rise from polypharmacy include drugs interacting with other medications or disease states in the patient, and then some duplications in therapy that can occur. There is also the prescribing cascade, which we've probably all seen. That's when a patient is put on one medication, they have a side effect, and then they're put on something else to treat that side effect. This also is an issue if people are not, if the dose of the first medication is not optimized, and then we keep adding additional things without reevaluating that first one. All of this can lead to a lot of confusion for patients if they're having this list of 20 plus medications, they're not sure why they're supposed to be taking it, and that can really lead to risk for errors or unintentionally reduced adherence. So I'm really going to focus on treating adult patients today because polypharmacy tends to accumulate over the course of someone's life as they have more chronic conditions that accumulate, and so that's what I'll really be focusing on. So studies have shown that people with CF take on average 10 or more medications, and so our patients are essentially a case study in polypharmacy. In addition to having a lot of medications and a large treatment burden, they have many different providers often prescribing those medications. They also have frequent transitions of care between the inpatient and outpatient world, although I guess not so much with our highly effective modulator therapy. They're also at risk for higher rates of renal and hepatic failure, which leads to some safety issues with medications. And then frequent changes in health status. So we need to be continuously reevaluating what medications are appropriate for that patient and not just be kind of complacent about this growing list of medications over the course of their life. So there's definitely an impact we can all make on polypharmacy, and I don't think I'd be a very good pharmacist if I didn't say that having a pharmacist on your CF team can absolutely reduce the risk of errors and improve medication safety. But we can all make a difference here. So anyone can do a medication history that is recommended to be done at least once a year for every single patient, if not more often, anytime there's a transition of care or a major change in their health status. We should also be optimizing current therapy before adding additional medications for the same problem. So a big one with this is assessing, are they actually taking the first medication? If they're not taking the first one, they're probably not going to take the second one either. So making sure they're actually taking that drug before just assuming it has failed is really important. And then again, optimizing the first of that dose, the first dose of the first medication before just adding something on is ideal to reduce the number of medications they need to take. Continuing to reassess that regimen, so deprescribing things that are no longer appropriate, and then I will talk about some resources for older patients like the Beers criteria and STOP criteria. And then I just want to remind everyone that non-pharmacologic interventions, so treating a condition without using medication therapy, is a great way to not only avoid polypharmacy, but is often first-line treatment for many things. So for drug interactions, I wanted to briefly discuss this so we all have kind of a general understanding. Most people just see that little pop-up window in their EMR that there is an interaction, and their first thought is call the pharmacy, which is appreciated. We like that. But I think understanding the basics is really important. So the different types of drug interactions you see here, cytochrome P450 mediated ones are the ones that occur in the liver. Those are those metabolic enzymes that break down medications. There's over 50 different types of these CYP enzymes, but there's only a handful that are responsible for most of our drug interactions, with the most common being CYP3A4. The reason that drug interactions happen is because medications can increase or decrease the speed of these CYP enzymes. So if you have a medication that's a CYP inducer, it is going to make those enzymes work more quickly, break down your medications faster, and lead to decreased efficacy of that drug. If you have a medication that's a CYP inhibitor, it's going to make that enzyme work more slowly. It's going to lead to higher levels of the drug in the body and increase your risk of toxicity or side effects. These are the most common types of interactions, but the drug transporter interactions are also things we see with CFTR modulators, so I wanted to mention those. That includes P-glycoprotein, which is a transporter that's located throughout the many areas of the body, like the gut, the blood-brain barrier, the liver and kidneys. Depending on if that is increased or decreased, and then the location of that change is going to impact the net result on other drugs. Organic anion transporting polypeptides, or OATPs, are another area. Those are more at a cellular level, so how fast or slow drugs are taken up into the cells in the body. Again, if those are increased or decreased is going to determine your net result on other medications. Absorption changes are a bit more straightforward, so anything that changes the pH of the GI tract can lead to different absorption of medications. It can also cause medications to be broken down at the wrong place in the GI tract, and so they're not going to be able to be absorbed where they should be. Physical barriers that are created by medications like sucralfate, physically coating the stomach, are going to inhibit absorption as well. And then lastly are binding agents. So if you have a medication that is physically binding to others in the gut, that is going to make them pass right through without being absorbed. An example of this would be why we ask patients not to take their fluoroquinolones like Cipro with calcium or dairy products. That's exactly what happens. They stick together and do not get absorbed. And then lastly, probably the ones that keep your pharmacist colleagues up at night are the unknown drug interactions that we just don't have enough information about because it's with unregulated products like over-the-counter medications or supplements, or just things that are so new and we just don't know how to address some of those interactions. The next thing to consider is drug disease state interactions, which I guess is a fancy way of saying think about all the things that are going on with your patients and that'll impact your medication choices. There can be several different things that impact absorption from a physical standpoint, like EPI, other GI disorders, history of bariatric surgery or feeding tube, hepatic function, renal function, and body habitus are probably going to impact the dose of drugs that we need to use. If a patient is pregnant, planning to become pregnant, or breastfeeding, that's definitely going to put some additional safety concerns into the picture. And so with the frequent contact that we have with our patients, I think evaluating their status with that is a really good opportunity for us to make some safe medication interventions. And then lastly, age, which I will talk a little bit more about next. So the Beers criteria is the first resource I wanted to point out. It's specifically guidance on medication use, safe medication use in older adults, so those over 65 years. It's published on an every 3-year rolling basis by the American Geriatric Society, and it focuses on minimizing medication risk, particularly with things that are more worrisome in older adults. A lot of things end up on this list because they increase drowsiness, risk of falls, or cardiovascular events. And as you can see here, a lot of very commonly used medication classes are on this list. So I do appreciate that the Beers criteria tells you in that document why things ended up on this list, and that way you can kind of weigh the risks versus benefits for a particular patient and decide if that's still something that you need to use. The next tool for medication use in older people is the start and stop criteria. STOP stands for the screening tool for older persons' potentially inappropriate prescriptions. This is published by the Geriatric Society and has some information on both medications that should be used in people with strong evidence over age of 65, as well as those that either show harm or lack of benefit in older patients. I think both the Beers criteria and the start and stop criteria are just good to be aware of as we kind of have an ever aging population in CF. So in the last half of this talk, I will review several different comorbidities that people with CF are seen to have more and more often. And so it's just as a general disclaimer, this is absolutely not going to be exhaustive. about these medications. I'm going to just highlight some specific considerations that we need to keep in mind for our patient population, just to keep things brief so we aren't here the rest of the week. Hypertension and cardiovascular risk is definitely a concern as our patients live longer lives and achieve higher BMIs than they have in previous years. So I would definitely suggest following the American Heart Association guidelines for both medication management recommendations as well as blood pressure goal recommendations. They do give recommendations for non-pharmacologic therapy, so I just want to point out salt restriction is one of those components and might need to be reevaluated for our population, especially if people are not taking a CFTR modulator. These guidelines do really advocate for using combination therapies whenever possible, because as you will see in this slide and the next, most patients will be, if you follow the guidelines, most patients are going to need 2 or more medications to manage hypertension appropriately. And so focusing on minimizing pill burden is really important here. Here you can see the two first-line options for all patients with hypertension. That is going to be either an ACE inhibitor or angiotensin receptor blocker, in addition to a calcium channel blocker. So right off the bat, we've got 2 more medications if they have hypertension. I want to point out for ACE inhibitors, a lot of people have avoided these in the past for people with CF because of the side effect of dry cough that can occur. I find that our adult patients know their kind of baseline level of cough that they have. And so just educating them that if that increases or if they have that side effect, let us know and we can change them to an ARB to avoid it. Both ACE inhibitors and ARBs are absolutely contraindicated in pregnancy due to a variety of congenital malformations, so those should be avoided if someone is planning or just not preventing pregnancy. Next is our calcium channel blockers. So the dihydropyridine specifically is first line. That would be like amlodipine. And one side effect I want to point out with amlodipine is peripheral edema, particularly in the lower extremities. That has been seen to be more common in people who are on higher doses. They're on it for longer durations, and also in female patients. If they don't tolerate amlodipine, they can be changed to a non-dihydropyridine calcium channel blocker. Those would be either verapamil or diltiazem. And I want to point out here that if they're on either one of those medications, they will definitely need a dose reduction of their CFTR modulator. So it's something to be aware of. Anytime they start or stop those medications, we need to adjust some of their other drugs because both of those are moderate CYP3A4 inhibitors. These are our kind of an add-on or alternative recommendations for hypertension. So the thiazide diuretics are going to be either second or third line therapy. When using these, we definitely need to keep in mind some monitoring because their electrolyte levels can be impacted by those medications. They're also not as effective in people with severe kidney disease with a creatinine clearance of less than 30 just because of how they work in the kidneys. Spironolactone would be fourth line therapy. And with that, I just want to point out that it is a potassium sparing diuretic. And so potassium levels should be monitored with this one because of the risk of hyperkalemia. It is also not the most ideal to start in someone who is having some serious issues with kidney disease because it can increase the risk of acute kidney injury. And again, this one should be avoided in pregnancy as well. Beta blockers are essentially going to be last line for treatment of hypertension alone, but if your patient has other cardiovascular disorders, this might be used more preferentially. One of the things that people have historically worried about with beta blocker therapies in anyone with a respiratory disorder is the risk of bronchospasm that can occur from beta 2 blockade. And so if you're concerned about this, you have a patient you think is kind of high risk for it, using a cardioselective beta blocker like metoprolol is probably going to be a little more conservative, safer option in those patients, although none of these are contraindicated in people with respiratory disorders. Beta blockers can also mask symptoms of hypoglycemia for some people. And so if you do have a patient who's already struggling with a lot of hypoglycemia awareness or a lot of lows, working through that before starting a beta blocker might be an ideal option. So another area of concern is our patient's age is going to be dyslipidemia. And at this time, there is no established correlation between dyslipidemia and cardiovascular risks in adults with CF, but we know that in the general population, that risk increases with age. So we would, at this point, kind of assume the same. The approach to treating dyslipidemia in people with CF is exactly the same as the general population, and the first line treatment is always going to be non-pharmacologic therapy. That includes maintaining a BMI within goal, increasing regular physical exercise, and then reducing the intake of saturated and trans fats and increasing omega-3 intake. If non-pharmacologic therapy fails, or if patients are just unwilling to make those changes, which we find a lot, statins are going to be the first line medication option. And so if those are started, we should not forget to monitor them or make sure that the patient's primary care doctor, whoever is prescribing that, has a plan to do so. We should be reassessing levels of their cholesterol after about 4 to 12 weeks, and then once they're at goal, about every 3 to 12 months thereafter. I also want to point out that recently in August, the U.S. Preventative Services Task Force updated their guidelines for primary prevention of cardiovascular disease, meaning a lot of our patients are now indicated to receive a statin if they weren't already. They're saying that patients who are 40 to 75 years old and have one or more cardiovascular disease risk factor and a 10-year event risk of 10% or greater should be on a statin, regardless of their cholesterol level. So since a lot of our patients are now over age 40, I just wanted to point that out. Those cardiovascular risk factors include things like diabetes, hypertension, and dyslipidemia. So that's going to be a lot of patients indicated to receive these drugs. And then lastly, regarding hypertriglyceridemia specifically, there are several studies showing that adults with CF have a higher risk of isolated high triglyceride levels. So we don't really know why that happens. There's a couple proposed mechanisms like inflammatory changes or higher fasting blood sugar levels. But the risk of that in CF is thought to be somewhere around 5 to 15%, which is much higher than the general population. We don't necessarily recommend starting medication therapy for hypertriglyceridemia unless their levels are extremely high, like over 500, or we need to rapidly reduce their risk of pancreatitis. If we do need to treat with medications, it's recommended to start with a statin first because that can improve the entire cholesterol panel. And then if additional help is needed to lower the triglycerides, there are some specific drugs for that. They're just not the most ideal. So to go into some specifics on these medications, the biggest one, of course, is going to be our HMG-CoA reductase inhibitors, otherwise known as statins. I get a lot of questions about statins because there are some medication interactions and also some overlapping side effects of statins with the CFTR modulators. So my recommendation in general is to avoid starting a new statin and a new CFTR modulator at the same time for patients. It's not contraindicated, it's not unsafe to do it, it just makes it much harder to troubleshoot side effects if you don't know which one might be causing them. Statins can increase the risk of AST and ALT elevations, which of course our CFTR modulators can do. So if a patient is on a modulator or has underlying hepatic disease, I would definitely be a little more vigilant about rechecking their hepatic panel, which you can just do in 4 or so weeks when you're gonna recheck their cholesterol anyway. I also wanna point out that statins can cause myopathy. There's not additional recommendations to monitor for that. But if a patient does have myopathy from their statin, checking a CPK is recommended. A complicating factor of that is that in the elexacaftor, tezacaftor, ivacaftor studies, some people had elevated CPK. So again, kind of that muddy picture of what is actually causing the problem, but statins are much more likely to cause that issue than the modulators. If additional therapy is needed, bile acid sequestrants can be added for dyslipidemia. Again, not my favorite option for people who take a lot of medications because of the risk of malabsorption of other drugs. So separating these from other medications is something that we should work with our patients on so that the things they're taking actually work. Fibrate derivatives are going to be our main option for treatment of hypertriglyceridemia. And as you can see by the list of side effects on the screen, they're not the most ideal for people with CF because there are some things they cause that we are already worried about in our patients. So that includes gallstones, pancreatitis, thromboembolic events, elevated liver function enzymes, and serum creatinine. There's a lot of monitoring that we need to do in these cases. So again, we can use them if absolutely necessary, but we try to avoid that. And then omega-3 fatty acid supplementation can help with hypertriglyceridemia as well. Most of these products are going to be over the counter, so they're not FDA regulated. The only prescription form is icosapent ethyl. It's a lot more expensive, and getting insurance coverage for it could be a little bit tough. But as far as these go, I'm absolutely fine with patients using them. They're generally considered safe and effective. I just try and, if people are using the over-the-counter products, recommending a kind of reputable brand is going to be important. A relatively new problem that we're seeing in people with CF is obesity, or people being overweight, thanks to our highly effective modulator therapy. So in our clinic, the dietitian and physical therapist are absolutely instrumental in helping people work through some of these weight loss goals that they might have. Unfortunately, since this is so new, we do not have a lot of studies in people with CF and the weight loss medications. So if, in general, if appetite suppressants or medications to increase metabolism and help them lose weight, if that's something the patient wants to do, I really recommend that they just limit that to really short-term therapy. If they need to use that to kind of jumpstart their plan for 6 or 12 weeks, I think that's okay. They should just have a plan for, either dietary modifications or physical activity to kind of sustain that change long-term. One medication I absolutely do not recommend in people with CF is orlistat. It is over the counter, so people have easy access to it, which is a real bummer. It works by inhibiting gastric and pancreatic lipase, which, as you probably know, our patients don't really need help with. It essentially just puts them at a higher risk of fat and vitamin malabsorption. So for safety purposes, I just do not recommend it. And then the class that I'm most excited to see some more data with in the future is going to be the GLP-1 agonists. That includes liraglutide and semaglutide, which are both injectable medications that now have indications for FDA-approved indications for treatment of obesity. There is really no data on these in people with CF. We have a couple of case reports that indicate these could be safe and maybe effective in our patients. But at this time, I would recommend, if you're going to consider this for a patient, doing that in coordination with your endocrinology colleagues. I think the most likely candidate for a medication like this is going to be someone who is overweight and also has some issues with their blood sugars that we're trying to better manage, although these are also used for diabetes but are not going to replace insulin for our patients, unfortunately. Changing gears a bit for the end. So hormonal therapies is another thing I get a lot of questions about, both for reproductive health and gender affirming care. Again, I just want to emphasize there's a lot of nuance to this. Anything in the general population still applies here. But fortunately for testosterone, there is no increased or additional concerns for people with CF. We just generally try and avoid those for safety purposes in people with severe renal or hepatic issues. Estrogen and progesterone are going to be a bit more nuanced. So fortunately, we do know that for contraception purposes, these work similarly in women with and without CF, so that's a positive. We do have some additional safety considerations to think about, though. So if patients have a history of thromboembolic disorders, especially if those are recurrent blood clots or things that are unprovoked, we want to really heavily consider not using an estrogen-containing product, and progesterone-only therapies might be the safest option in those cases. Oral combined contraceptives are not recommended in people with severe hepatic disease and pulmonary hypertension. And then long-term use of depomedroxyprogesterone has been associated with a loss in bone mineral density in all people. So with this being even more of a concern in people with CF, it's just not the greatest option for long-term use. then lastly, some interactions we need to think about here. Strong CYP3A4 inducers like rifampin and lumacaftor are going to increase the breakdown of estrogen and progesterone and make them less effective for our patients. I also educate people when they're starting elexacaftor, tezacaftor, ivacaftor that women in some of the studies who were taking hormonal contraception had a higher risk of that drug-related rash that can happen with these medications, and that even included hormonal IUDs in some of those patients. So when discussing kind of reproductive health, specifically in contraception, I think it's really important to remember that people with CF have similar sexual behaviors to the general population, and we should be counseling them accordingly. So I just want to point out this resource, which is the U.S. Medical Eligibility Criteria and Selected Practice Recommendations. They have an app. The logo is here on the screen, and it is super user-friendly. It gives really practical, evidence-based recommendations for contraceptive use. And I found it really, really helpful. So I just wanted to point that out. I'm gonna skip that one for time. I was asked to talk about erectile dysfunction, so we'll end with that. To be honest, this is an area my clinic immediately refers to either primary care or another specialist, and we don't manage in the pulmonary clinic. But I think it's important to generally understand what we're working with here. So if they have a other medical condition or hormonal imbalance that's leading to that issue, correcting that is going to be really important, including treating any hormonal imbalances. There's a lot of medications that can increase the risk of erectile dysfunction, especially SSRIs and antihypertensives. So if there's a medication that might be causing that, trialing alternative therapies, if there's another option, is a great way to help reduce that side effect. Choosing between these is really patient preference, cost, accessibility, and then phosphodiesterase 5 inhibitors tend to be first-line treatment, and the options for those you can see here. There's 4 different medications, and they are very similar between each other in terms of efficacy and side effects. I will just point out, like, a key difference between these is tadalafil tends to be the most different from the others. It has the longest duration of action, is the only one that can be taken once a day, and that can help patients if they're having issues with timing of these medications. It's also the only one that doesn't need to be taken with concern to food, so it can be taken with or without, whereas the others should be either taken on an empty stomach or take longer to work if they're taken with food. They all have the same drug interactions and side effects, essentially. So keeping in mind that if patients are on nitrates or alpha blockers, they're at a higher risk of syncopal events and hypotension. And then Orkambi, if they're taking Orkambi, it is an inducer and it's going to make these ineffective, essentially. I am going to not go into a lot of detail about dietary supplements because there is an entire symposium on this today at 3:30. So I would recommend going to see them if you want more information on that. And just to kind of sum things up, I think there's a lot of opportunities for us to impact polypharmacy because of the kind of close, frequent contact we have with these patients. There's definitely an opportunity for everyone to work through some of those considerations and help our patients live longer, healthier lives that aren't as complicated by their medication burden. So continued reevaluation of medications is super important and something we should all be aiming to do for our patients. You can take any questions.
I have a question.
Yeah.
Great talk, everyone. Thank you. Is that in mind? What do you think about that?
Yeah, so total oversight on my part. Realized literally last week that I left that out. So ezetimibe is another lipid lowering therapy that can be used for elevations in LDL particularly. Same side effect with the statins, essentially. So the main thing is going to be also looking out for any impact on liver function. I would probably do the same thing I would do with statins, which is check AST and ALT in like 4 to 6 weeks, just to make sure it's not increasing that. Ezetimibe is a good option. I completely forgot it. So thank you. Yeah.
With contraceptive use, you mentioned a rash. Is
Yes.
that a rash related to Trikafta or related to contraceptive?
Yes, good question. So the rash is related to Trikafta. It's not an allergic mediated rash, and so that's something I definitely educate patients on because, of course, rashes are scary and we immediately want to stop the medication that's causing them. The rash was something that was seen like in patients who were already taking a hormonal contraception or had a long-acting method that was hormonal. When Trikafta was started, some of those people had an increased risk of drug rash. So, likely an increased risk with Trikafta itself and not the hormonal method. But one key thing to know about that rash is that it is not allergic mediated most of the time. And so we can just, if people can tolerate it, they can continue to take their modulator. In really severe cases, I've had people stop the modulator, let that rash resolve, and then restart it in about a week, and the rash doesn't come back. I have no idea why. I don't think anyone does. So we haven't had that be a reason why someone could not take a modulator, which is good.
Thank you so much.
Yeah, thank you.
Okay, lastly, we will hear from Kristen Clem, who's going to talk to us about food insecurity in CF.
Hi, everyone. All right, I'm really glad to be here today. I am Kristen Clem. I work with the CF Foundation, and I lead the CF Food Security Committee. So I'm here representing them and all of the work that they've done. The committee has been together since 2018. They have, it's about 26 clinicians or individuals, mostly clinicians, different disciplines, some small care teams, some large care teams, rural, urban, pediatric, adult, so it's a really nice combination. And there are also individuals with CF and caregivers on the team as well. So the work I'll be presenting today is, many of you contributed to it, and for that I'm really grateful. Okay. I do not, oh, slide issues. All right, I do not have any relationships to disclose related to this presentation. So I really have two goals for today. The first goal is I hope that you leave here having learned something new about the impact of food insecurity on people with CF. The second goal is I hope that you leave here feeling supported, that you've learned about some new resources that can help you and your team and your patients if food insecurity is something that you are working on with them. So starting off, what is food insecurity? What does this term mean? I know I just said what is food insecurity, but I'm actually going to talk about it now in terms of food security. So you'll hear the two terms, food security and food insecurity. The USDA defines food security as access by all people at all times to enough food for an active, healthy life. A definition that I tend to use for food insecurity is lack of access to enough healthy, nutritious food. The key terms I want to point out in these two definitions are healthy and nutritious. They're, especially with Trikafta and the changing dietary needs of people with CF, we can't just focus on quantity of food, there needs to be some focus on the quality of food they're receiving as well. So you'll see the scale here, the upside down pyramid. Food security can be seen as a scale. At the top, people having regular access. At the bottom, people having very inconsistent access to the food. And typically the bottom two, the orange and the red, are considered what is considered food insecure. So now,
Sorry, we just go a little closer to the mic.
oh, I'm sorry if you can hear me.
Thanks.
All right, so now that we have a basic definition of food security and food insecurity, let's talk about what we know about food insecurity in CF. So the first study that we have on food insecurity was back from 2009. This study explored household food security, knowledge of nutrition, and self-confidence in one's ability to manage components of CF care. This was the first time that we learned anything about prevalence of food insecurity among people with CF. So at the time, in 2009, the national rate among Americans of food insecurity was 14%. this study found that 26% of people living in Arizona, Colorado, New Mexico, and Utah were food insecure. So the number was almost double. The clinicians, the researchers, were also surprised by these high rates, especially given the high household income of their patients. And they hypothesized that this was a reflection of the high expenses of CF care, like copays, the need for vitamins and supplements and extra food. Finally, the researchers identified that there were benefits to screening for food insecurity, so healthcare professionals can respond accordingly with nutritional interventions, and that to make appropriate referrals to community resources. The next study that we know about was almost 10 years later. This study sought to better understand the prevalence of food insecurity among CF patients in Idaho. So this study also looked at the prevalence, like the previous one did, and it found that 33% of children with CF and 43% of adults with CF were found to be food insecure, which these numbers are pretty shocking for me. At that time, in 2018, the rate of food insecurity among all people in Idaho was 15%, so the rates of people with CF were more than double and almost triple the state rates. From the study, it was the first time we learned about something called a trade-off that people often have to make. And what that means is when money is tight, there's something you can't pay for everything. Unfortunately, sometimes people have to choose between paying for their medications or paying for food for their families. And chances are they might be choosing to pay for food for their families and forgoing their really necessary medications. The researchers, again, just like the last ones, commented on the value of assessing for food insecurity, but especially among all patients, not just the ones that you suspect may be food insecure, and recommended addressing it as aggressively as possible. So then the remaining studies that we'll discuss were published within the past 2 years. It's really just been in the past 2 years that we've learned so much about food insecurity. This study explored the association between food deserts and CF outcomes. So this is the first one that really looked at outcomes. So it's really interesting for us. The term food desert may be unfamiliar to some, but it's defined as a geographic area in which it's difficult to buy affordable or good quality food. So you can think of a geographic area where maybe the only place a person has to go for all their groceries is a convenience store, as opposed to a geographic area where there is a supermarket every few blocks. And what they found was that independent of most social determinants of health, people living with CF in a food desert had a lower BMI and increased odds of having suboptimal lung function. Researchers in the study also, like the others, suggested that routine screening for food insecurity is vital. The next study that was published in 2021 is a little bit broader than just food insecurity. It explored implementing a social determinants of health questionnaire. I'll skip down to the third bullet point here to talk about what they found in terms of food insecurity. And they found that people receiving disability were more likely to report hardships than those who were employed. Again, like the others, they suggested that implementing this was feasible, implementing screening was feasible and beneficial for people with CF. So this one's a little different. It's a blog post called What It's Like to Experience Food Insecurity as a Person with CF. And this blog is a really moving reflection on about the stress and embarrassment and fear and shame that someone experiences when they're food insecure. So I really highly recommend reading it. It's available on the CF Foundation's website. I'm not going to read everything here, but I'll read the highlighted quote. I feel guilty because I'm not the hardworking person contributing to society. Instead, I'm someone who lives on entitlements. Funny thing is, I don't feel entitled, I feel shame. The next study was published in 2021, but it was actually conducted in 2019. So it was pre-COVID, pre-Trikafta. We know a lot has changed since 2019. This was a national study, and it looked at the association between financial and coverage-related risk factors and food insecurity. So what this found is that 1 in 3 people with CF experience food insecurity, 33% of people with CF. And this is the current statistic that we use because it was a national study. It also found that the odds of food insecurity are 19 times higher for people with CF with a household income less than $30,000 compared to those who have a household income more than $150,000. The third finding, while it found that publicly insured individuals have a significantly higher odds of being food insecure than those who are privately insured. The next study was published in 2022. It was just recently published this year, and it looked at food insecurity, the impact of COVID on food insecurity, mental health, and self-care in people with CF. Again, the study looked at a lot of outcomes, which has been really interesting for us to learn. It did find that food insecurity increased due to COVID, but it also found that people who reported food insecurity reported weight loss, worse airway clearance adherence, and worse medication adherence. It also found that people who were food insecure reported worse mental health. So this is the last study I'll share. It was just recently published. It's a qualitative study on the experiences of people with CF surrounding food insecurity. They did interviews. And there are 5 major themes, which is the perfect way for us to end this part of the presentation because it summarizes what we've heard from the others as well. So the first theme, food insecurity is influenced by a variety of factors, ranging from nutritional demands to competing financial barriers. We heard about the trade-offs that people have to make and know that CF care is expensive. The second, food insecurity impacts CF health outcomes. We heard it impacts BMI, it impacts mental health, it impacts many others as well. Third, open patient-provider communication around food insecurity is vital. We heard about the shame and fear and embarrassment that a person experiences, so as you can imagine, having that strong relationship is really important for when you're having discussions about food insecurity. Food insecurity screening and discussions should be normalized in CF care. So to normalize screenings, everybody should be screened, like we said earlier, not just the individuals that you think may be experiencing food insecurity. And then that comprehensive resources are vital. Okay, so now that we have a baseline, what are the resources to support you, your teams, and your patients? All the resources that we're going to go through today are available on the my.cff.org resource library. And this was already mentioned, but to how you access that, visit my.cff.org, click on the little button for resource library, and then you can search for food insecurity or food security, and any of the documents that we discussed today will come up. If you have issues logging in, I have 2 tips for you. First, talk to your clinic coordinator. Make sure your name and email address are part of your team roster. Second, if that doesn't work, you can email the address on the screen, and they're pretty quick to respond and can help you get access. So this is the Food Security Index, and we're going to spend most of our time going through this. We just created this year, and it's a really nice summary of the documents that have been created to support care teams around food insecurity. Most of these were created by the CF Food Security Committee, but some of them were created by other groups. As you can see, there's a QR code on the screen, so feel free to use that now and pull it up. Or again, visit my.cff.org and search for Food Security Index. So and I'll pull this up several times throughout the presentation. When we created this, we wanted it to be actionable for you. So as you're working on food insecurity, you can kind of start on the left and work your way through. What we have in each section are, there are links to the documents. Again, goes back to the resource library, so it's really key to have access. And then a really short description about what the document is. So starting off with the define section. In this section, you'll find documents to help you define and understand food insecurity. There are 3 documents in this section. The first is the Food Security and CF Summary Report, and it summarizes key data and knowledge on food insecurity, so a lot of the things that we discussed earlier. It sets a really nice stage for understanding the issue, and I recommend this as a good place to start. The second is a presentation on federal nutrition programs. We have this available in 2 different versions. One is a video version, it's on YouTube. The second is a PowerPoint with the script to the video in the notes section, so you can go through at your own pace. This is presented by Kathy Cooney, and she's a social worker in Rhode Island, and she worked with the team of clinicians on this presentation. And after they were done, the information was reviewed by experts at the Federal Food Research Action Center, or otherwise known as FRAC. And it provides a great overview of SNAP and WIC with background information that might be helpful for you or your teams to know. The third document in this section is a handout, what we call a handout for clinicians, and it's a nice complement to the first report. So while the first is mostly facts, this provides some more tips for care teams to start thinking about if you're thinking about implementing anything related to food insecurity. Plus, it has some more information about where to go to learn more about social determinants of health more broadly. The next section is Learn, and the documents in this section are intended to help educate and prepare your team for action. Again, three documents in this section. The first two are pretty similar. The first one is called the Quality Improvement Change Package. This is a very large document, it's pretty extensive, that will walk you through either improving your screening and interventions process or starting one, really from start to finish. It has 4 main sections: background, your team, screening, and interventions, all followed by an appendices with that's just packed full of information. This was created by a pretty large multidisciplinary team, and it was then tested by 5 different care teams over a 6-month period, and we used their feedback to improve it. Like I said, it's a really long document, but we do recommend doing this over 6 months to a year, over a long period of time, so it is actionable. And then the second is just a shortened 2-page version of the Quality Improvement Change Package. It has similar topics, and it has links to many of the documents that we'll talk about today. The last document in this section is the PEP discussion aid. There are several discussion aids out there, and they're all really helpful, but this one focuses on food insecurity screening and interventions. There are PEP tips, pearls, art loops, and then an actual conversation utilizing PEP tips. So that's so you can see it in action. The next section is called Screen, and it includes resources to help you identify food insecurity. Again, three topics, or three links in this section. The first is a chart of validated screening tools, and this was developed by Dr. Keith Robinson in Vermont. It includes short descriptions of the screening tools as well as a link to access them. Currently, there is not a validated screening tool in the CF community, so all of these are really great options. And many of the tools go beyond just food and include things other social risk factors like housing and employment and more. The next is a webinar that we hosted earlier this year. This was a result of the testing of the Quality Improvement Change Package. The feedback we heard was that the teams wanted more guidance on how to screen and intervene with sensitivity. So what we did was we pulled together some partnership enhancement program PEP facilitators. So in this webinar, they provide tips and also do a role play. And then we have a panel of several different clinicians, as well as an adult with CF and 2 parents of children with CF. The tips are really helpful and the stories are really moving, so I also recommend watching this webinar. And then the last in this section is a screening log that you can use to track your patient's results. So our next section is Intervene, and it provides documents and tools to support your team in connecting people to community resources. This is our largest section, and I think it's also an area that clinicians are generally a little bit more hesitant about. We've heard that some clinicians are hesitant to screen because they're not sure if they have interventions to provide or resources to provide with their patients. So hopefully this category can help with that. So the first document is a handout that you can easily print and give to your patients. It provides information about what is food insecurity, how food insecurity impacts people with CF, why they should talk to their care team, and then what they should do if they are food insecure. And it also has a full page of resources that they can reach out to, as well as a blank page with lines that you can use to fill in some of your local food resources or use as a conversation so they can take notes. The next 2 are for anybody who's looking to start an intervention in their clinic. The second one is starting a food pantry in your clinic, so a guide on how to do this. As a food security committee, this was the #1 request that we've received. As clinicians, everybody's interested in starting a clinic in their pantry and want to know how to do it. So we interviewed 8 different care teams who have started food pantries in their clinic and used their tips and tricks and best practices to create this guide. There's a flow chart at the beginning, followed by all the sections broken down, so it's a really helpful guide to do so. And the next document is called Unique Interventions for Food Insecurity. And each page of this Unique Interventions document talks about a different unique intervention. Anything from sending food boxes to your families to getting hunting and fishing licenses so your patients can hunt or fish for their own food. Each page was developed by the team who created that intervention, and it has the steps that they took, tips from them, and then the resources that they need so you can identify if that intervention is right for you. The fourth item on this list is another handout. But this one is a little bit different. It has fun facts and games and activities, so it's intended for teens and children. It's great to print out and give to them between visits with different clinicians or if they have some downtime. There are 4 different documents for kids and 4 different documents for teens, so they're intended to be used they could be used throughout the year during the quarterly visits. And then the last document in this section is a chart on WIC referral forms, and the chart provides links to WIC referral forms by state, as well as some others that might be needed for special formula or supplemental food. And finally, our last section is advocate, a call to action for clinicians. The first one there are only 2 here. The first is a document on how to be a food security champion for your community, so how to lead efforts for your local CF population. There are tips on letter writing, so how to write a letter to WIC for whole milk, or how to write a letter to the school for double portions. And then there are also other suggestions and talking points that you can use in advocacy efforts. And then finally, there's a link to the CF Foundation's website where you can sign up for advocacy alerts and learn about any local opportunities to get involved. So I have 2 more resources I want to talk about that aren't related to the Food Security Index or not part of that index. The first is Compass, which many of you may know about, but it's a really great team of patient advocates that can help connect your patients to local and national food resources. But they can also really support you. We know you're very busy, your time is limited, so let them do the research, partner with you to help connect your patients. And then the last one I want to share today is the Social Determinants of Health Toolkit. This is our newest document that actually was just finalized last week. And we've been working really hard over the past year to develop this. It's not just focused on food insecurity, but there are food insecurity tips and tools and resources throughout this document. To create this document, we worked really closely with the Compass team. We worked with the Partnership Enhancement team to facilitate the PEP facilitators. And then we worked with more than 50 clinicians and individuals with lived experience to review the content. And so we feel really confident providing this to you and hope that it's very helpful. In it, you'll find 3 different sections. So section on knowledge, it can help inform you, educate you more about what social determinants of health are. There's a really handy chart that goes through everything that we know about social determinants of health and CF. There's a section, the middle action, so what you can do if you want to take action. There are things like a link to screening tools, PEP tips, ICD-10 codes, guidance on incorporating SDOH screening into your electronic medical record. And then the last section is the resource section. In this section, we have full pages on the following topics: broadband or internet access, food insecurity, employment, financial wellness and health insurance, and utilities. And for each of these sections, we talk about what the data, what the impact is that we know about, what you can do on these topics as a clinician, as well as what are some PEP conversation starters. And then each of these topics also has a patient handout that you can print and give to your patients. It gives them tips on what they can do, how they can find support for these topics. So this is also, like everything else, available in the my.cff.org resource library. It's also available on the NACFC app. So if you go into the app, open up, I think it's called the resources section or resources, I don't remember, but search for SDOH, and you can have that emailed directly to you. So you'll have that when you get back to work. So that's all I have to share with you today. I hope this information was helpful, and I wanted to have my contact information on the screen, because if you email me, I'm happy to share any of these resources with you. One thing that we also do is connect clinicians with other clinicians who have experience doing what they're interested in doing, or firsthand knowledge on the topic. So I'm also happy to do that. So I'm happy to take any questions, but also please feel free to email me.
Thank you, Kristen. I have a question that came through on the app here for you. It's kind of long, so if we need to break it into sections, we will. Do you have any recommendations on the best way to assess food insecurity? Do patients tend to be open to disclosing this? Should that happen via in conversation or a less personal way like a paper survey?
There are some studies that I know about that have looked at screening on paper versus through conversation versus electronically, and my understanding that electronically might be the best way to get the most results, perhaps the most anonymous. But I think utilizing those PEP skills, building strong conversations, it's really important to have that trusting relationship, because a lot of individuals have fear of disclosing this because of potential repercussions. So really creating that strong base and having a strong relationship is key here.
Thank you. Do we have any other questions for Kristen?
They're not, but we do hope to translate all of the patient handouts into Spanish.
Okay, we've got another one here on the app. The question is, do other centers encounter challenges or limits in offering families grocery gift cards, and how do other teams manage that?
I would recommend that you take a look at our food pantry, how to create a food pantry document, because it does touch on this topic. I don't work in a care center, so I don't personally have experience with it, but there are likely, there might be some hoops that you have to jump through with your administration. I have heard of some teams fundraising for gift cards or working with outside organizations to provide them.
Thank you. Are there any other questions for Kristen or for any of the other speakers today?
Thank you.
Thank you.